across yours link and my fellow colleagues. I am Dr. Reshma Parekar, Medical Advisor for Gynec and Dermatology Divisions of Lupin. Welcomes you for today's session. Lupin clinics always stand towards the advancement of standard drug care and upliftment of a women's health. A global network of state-of-the-art manufacturing facilities which helped build scale and enabled us to meet customer needs. Our maxim is to understand women and help her with associated ailment at various stages of her life and to make it more productive. Today, we would be discussing something very elemental as the acquired importance in human life revolves around iron. We all need iron, which is naturally synthesized in our body and can be obtained via various food sources as well as different organic sources. It's an essential component of hemoglobin, protein that transfers oxygen from the lungs to the tissues. From ancient times, man has recognized the special role of iron in health and disease. Iron had early medicinal uses by Egyptians, Hindus, Greeks, and Romans. However, its concentration in body tissues must be tightly regulated because in excessive amounts it can lead to tissue damage. Disorders of iron metabolism are among the most common diseases of human and encompasses a broad spectrum of disease with diverse clinical manifestation ranging from anemia to iron overload and possibly to neurodegenerative diseases. Today, we have a privilege to share the dais with pharmaceutical researcher and practitioner at the same time to understand more about the iron economics. I welcome Dr. Mukesh and Dr. Gaurav. To begin, I would like to share a brief introduction for our speakers. Not only being one of the busy practitioners, Dr. Mukesh is IIM Calcutta Alumni 2021. He is a President, Association of Medical Consultants 2019-2020, past President for Association of Fellow Gynecologists Mumbai, as well as past editor, The Grasp AMC. He is a winner and awarded for Emerging Star of Medicine, Young Achievers Award, in Excellence in Healthcare, as well as Young Achievers Awards in Children Academy Group of Schools. Core Committee Member, Mindspace ALM Malad, Mumbai, Lions Club Malad, Borivali 2020 to 2021. Welcome on board, Dr. Mukesh, and I hand over this session to you.
Thank you for your kind words, Reshma. So I'm extremely happy to be here amongst you. And the topic today that we're going to be discussing is a little offbeat because we've been discussing about anemia in pregnancy, and we've been discussing about so many more things related to iron metabolism. So today we're going to be discussing something which is the iron economics. Now, why is it that a clinician is interested to know about it? Why, as a clinician, we need to actually, really look into these basic things and basic aspects about planning about the whole metabolism of iron? Well, it is one of the most integral part of our practice, dealing with anemia in women, dealing with anemia in pregnant women, dealing with anemia in adolescent. And that is the reason why we need to be extremely sensitized and aware about the changing dynamics of iron and the direction that the science is moving to. So with this kind of mindset, let me just quickly try to make you understand that when we are talking about the burden of anemia, there has been a huge, let's understand that it's not a small number that we're talking about. We're talking about lakhs and lakhs of people who are getting affected. This is a National Family Health Survey, which says that be it any age that we can think about, we are facing this problem of anemia. And we are talking about, when we talk about pregnant women, more than half of it are going to be there. It is cutting across any of these states. And well, I am sitting in Maharashtra, which is down here in the ladder, but states like Bihar, Gujarat, West Bengal, it's really showing a huge prevalence. Now, when we want to talk about anemia as a clinician, we all know the different signs and symptoms for anemia and how we want to look into it. So I'm not wasting my efforts into that, but my focus today for this conversation is going to be on the diagnosis and the patient centricity of managing anemia. Because at the end of the day, as clinicians, we all have to realize that it has got nothing to do with what you know and what you're aware about, but it is about the patient listening to what you're saying and what your knowledge is helping them to do what they want to do. And that is where we need to start focusing on how we can achieve the outcomes that we intend to when we are trying to handle a patient of anemia, especially a pregnant woman. Now, when we talk about the investigation, there's a huge set of investigation that we are talking about. We're talking about the basic hemoglobin that we are always doing. One of my favorite investigations now is not just the hemoglobin, but I add ferritin to it. Now, why do I add the ferritin levels and investigation of ferritin when I am doing an evaluation of a pregnant woman for anemia? Well, when we talk about a simple iron deficiency anemia, there are so many things that we also want to look at. So these are the options that we have. So we have the low MCV, we have the low ferritin, we have serum iron, we have got low iron saturation, TIBC combined, iron binding capacities. But we need to also understand it's not just about these investigations, but they have specific roles to interpret what is the status of iron or iron stores inside the woman's body. So hemoglobin is more about a marker for the erythrocyte iron, whereas ferritin is a marker for iron stores. Now, it's high time that we move on just talking about the erythrocyte iron, but we start moving about and thinking about how to get a better outcome by also looking at the stores. If we are looking at a situation where a woman is having inflammation, then a TSAT, that is transferrin saturation, is something which really helps us in a better way. But more than that, it's a soluble transferrin receptor which will help us in some of those rare cases. So meaning the mobilized iron can be reflected by TSAT. So let us try to understand that when you're looking at iron deficiency anemia, if not anything else, at least remember that hemoglobin and serum ferritin are two utmost important investigative tool that we have, and add to that the soluble transferrin receptor studies, which will help us to diagnose iron deficiency. Now, this is a little interesting way to put the iron stores and the circulating iron. When we talk about the iron stores, normally we expect that it should be full, but there may be a possibility that the circulating iron, that is the hemoglobin, is still at a normal range, but the iron balance is still not good enough and the hemoglobin in the store is not good enough. Now, if the store is depleted and the hemoglobin is depleted, then we see what we normally see in the patients with severe anemia, that the ferritin level is low, TIBC is high, serum iron is also low, the saturation is less than 10%, etc., etc. But there might be a situation in between this normal and iron deficiency where you may find the findings a little different. For example, here the hemoglobin may be fine, but the serum ferritin levels are pretty low because the store is less, yet the hemoglobin levels are not so low. Now, this is where we need to start focusing on. We'll talk about a little management plan for these things a little later, but let us try to see that if besides this basic iron deficiency, there are some other investigations like the stool test, the HB electrophoresis, when you want to rule out and figure out if there is a risk of thalassemia, we look for. But one of the primary things when we talk about iron metabolism is the GI tract. When we talk about the GI tract, the thing that comes in my mind is that how do we evaluate whether the iron absorption is happening in the first place appropriately or not, and what is the impact of it? So today we are going to also focus on how the physiology at the GI tract gets altered when we are giving a patient iron therapy, or the other way around, what is the impact of iron therapy on the GI tract? Well, for that, we will be having a specialist talking to us a little while from now. But let us start understanding the basic issues of how the iron metabolism, is affected and what role this has to play. So the moment we look at this, let's start with the reverse thing. So what is the amount of iron that is excreted? Now, I always say that the terminology is, it is a one-way metabolism, meaning whatever iron we are dumping inside the body, it does not easily come out. Meaning that the amount of iron excreted from the body is more or less standardized. When it comes to a male, it is 1 milligram, menstruating female is 2 milligram per day. And when there is a marked iron load, maybe 2 to 4 milligram per day, which goes in feces, exfoliating cells, and skin cells and urine. Well, if we keep on dumping iron inside the body, it can definitely lead to a toxicity status. Hence, our body has a mechanism to not to allow excessive iron be absorbed inside, so that only that much amount of iron is absorbed from the GI tract that is needed by the body or that the body can tolerate. This brings us to the funda of iron distribution. Now, iron distribution is heterogeneous, meaning 1 to 2 milligram per day is getting absorbed from the body. And once it's getting absorbed, it adds up to that amount of iron which is released from the disintegrating RBCs and is picked up by the reticuloendothelial macrophages. And from there, it is stored in the liver parenchyma. Now, mind you, that in liver, the iron stores are in the form of ferritin, which I can, which can be reflected here. It is in the form of ferritin. Now, this partly is used for manufacture of the new ions in the erythroid series, or a new hemoglobin in the RBCs, or it can be stored also in other tissues and muscles. So in simple words, the transfer is happening through transferrin, and the storage is happening through the ferritin molecule, which is there in the liver parenchyma. But the absorption is happening through the enterocytes in a very limited way. Now, here comes the game of hepcidin. Now, this is what I wanted to talk about today, that how hepcidin has an impact on the management of the whole iron absorption system. Now, let me explain another thing. So, if a patient walks in and says that, okay, my hemoglobin is less, so doctor, I don't want to have iron, why can't I have, say, 3 tablets, 4 tablets of iron daily and quickly make it right? Okay. Or we have seen people giving overzealous iron therapy, and instead of the required doses, double the dose or increase the dose, and then we start thinking that, okay, if we are having this high dose, it will be beneficial to us, and let's try to do this high dose. Okay. Now, what is it that goes wrong when we do that? When we do this, the biggest thing that goes wrong is this, that normally whatever we eat in the food, the iron, if it is a heme component, it is a different heme transporter and gets absorbed and it gets utilized. But if it is a ferrous or a ferric form, it gets transported into ferric, converted into ferric form, and then through the DMT1, it is absorbed inside the cell, and again through the ferroportin, it is taken into circulation. But if there is surplus amount, then there is a mucosal ferritin complex which is formed, and that actually is shed off from the mucosa. Now, this is called as the mucosal block theory, meaning the enterocyte mucosa actually is going to be shed off if there is excessive iron. Here comes the role of liver. The moment the liver, okay, is given the message that the iron is surplus in the store, that is being absorbed, it produces hepcidin. And now this hepcidin actually comes back to the ferroportin, which is required for the absorption and transfer of this ferrous molecule, iron molecule, into the circulation. It stops the ferroportin and inhibits it. So in simple words, if we give an overdose of iron, it is going to impact the liver and the hepcidin mechanism, and it is going to stop its absorption primarily. Meaning, if you're giving, say, 100, 200 milligrams stat, and then you're giving the next day, by the time the next day iron tablet is given, or already the ferroportin has been blocked by the hepcidin from the liver, and it is not going to get absorbed. So the second day iron that you're given is all going to be passed on through the feces, and it is not going to get absorbed. So this is an interesting conversation I had with hematologist. I need to thank Dr. Abhay Bhave for this. He actually explained me the whole system. Once I had a long chat with him, and then I attended a few sessions with him, I realized that hepcidin mechanism is not so simple, and you need to realize that this decides on that. And when I started digging into literature, I also realized that what is the best time to give the iron? The best time to give the iron is the first half of the day, because hepcidin release is higher in the second half of the day. So the absorption of iron is better in the first half of the day. So hence now my prescription always writes iron tablet, maybe a few hours after the breakfast, maybe not with the milk in the breakfast, but maybe after that, but I give it in the first half of the day. Okay, so there is a role to play about the timing. Now, when we talk about anemia in India and gestation, let us try to go and focus on the Barker's hypothesis, that is fetal origin of adult onset disease. So when we're talking about fetal origin of adult onset disease, what is one very important component is what happens here has an impact not just here, but all through the journey of the life of a child. Meaning the intrauterine exposure to various different aspects is actually going to program the baby right at the, at the prenatal stage, and which impacts the incidence of the hypertension, diabetes, and ischemic heart disease at a later age. Now, add this component of anemia here. Now, one of the factors I always say is either the oxygen carrying capacity, that is anemia, or the nutritional aspect, or the hormonal impact. These are the three primary ways that the fetal programming can get altered. Now, if we are not paying attention to these three things, then definitely the outcome is going to be for long term. And this will lead to a vicious cycle, meaning a woman who is not healthy will give birth to another child who is going to be, having a health which is below par. And then an anemic child grows up into another young adolescent with anemia, with its own set of issues during the growing years. And again, when she becomes pregnant, she again gives birth to another child who is anemic. So this is a vicious cycle. Somewhere we realize that as doctors, it is our role to correct that. So when we talk about the anemia journey in pregnancy and correction of that, now, as I showed you in the earlier slide about the three different aspects, the storage iron, the transport ion, and the erythron are the one which is there in the hemoglobin. Now, if everything is normal, fair enough. If there's a simple iron deficiency, meaning the hemoglobin is not so low, hemoglobin is normal, but the serum ferritin is low. Now, this means the stores are depleted, and we really need to pay attention to the store, because it is recommended that if you want to give iron for patient who is delivered even with normal hemoglobin, at least for 2 to 3 months, you need to give iron tablets to take care of the stores. So this can be taken care by oral medications. But if, for example, in the second trimester, that is especially the later part, if we land up with a situation where not only the hemoglobin is low, but also the stores are depleted and the transport ion is also low, that is the transferrin saturation is also low, this is a situation where we need to be a little aggressive. The highest amount of iron required is in the last few weeks, actually the third trimester. It is the last few days. I would say the last 100 days is more important than any other days. Okay, so this last few weeks are the most important time during which the iron is needed, because not only does it help in oxygen carrying capacity, but also it reduces the risk of complications, and our most dreaded complication, the PPH, it takes care. So at this point, we need to pay attention that if the hemoglobin is not so good and iron stores are pretty low, we can consider the parenteral prescription or injectable iron therapy, for a simple reason that it will help to get the iron increase faster and ensure the compliance matter. But obviously the oral is first choice because the absorption is very nice. So if we look at the anemia kicking in at different times, and if we do look at the journey of the woman during pregnancy, we need to think that it is the last few weeks, that's very important. But if we are able to identify that at the beginning, and we know that hemoglobin is low, and we know that it is iron deficiency, and it is not about thalassemia or sickle cell anemia, then we need to start working right at the beginning. Now, there's an interesting, this was an interesting slide I got from Bothwell and all, the American Journal of Clinical Nutrition, which talks about requirement of iron in different phases and ages for a woman, as in non-gravid state, that is preconceptional period, to the prenatal period, and then postnatal period. So if we look here, the requirement of iron per day may be pretty low in the non-gravid state. And even the first trimester, it may not be really high. But the moment she enters into the second trimester, the requirement starts rising drastically, because the requirement is for increased RBCs in the circulation as well as the fetus and the placenta. And the moment the woman delivers, then again we need a little bit of extra lactation, extra iron as compared to earlier state for the lactation period. So in simple words, when we are talking about the requirement of iron, it is the second and especially the third trimester where the iron requirement is pretty low. Now, if we give it a number, then in the third trimester, sometimes it may be as high as 6 milligram per day. So what I want to tell you is that if we do not pay attention to the requirement of iron in different times of pregnancy and preconception and post-conception, post-delivery phase, we will miss out on basic understanding of how to help a woman with anemia, which is one of the biggest things. So this is a very amazing slide, which I love to, go back to again and again for understanding about the requirement. Now, let us understand another concept. Now, this concept is about how the higher dose of iron, is going to be impacting the whole system. So if we are giving high amount of iron, the salt iron, the ferric form will convert into ferrous form. And then the ferrous form will be getting absorbed by the DMT transport system inside the cell. And once inside, it will actually be transported beyond the enterocytes by the ferroportin. So this we actually saw earlier also in the slide, that how the ferroportin is important for transport of the ferrous. But the surplus of ferroportin is going to actually be accumulating in the enterocyte, and that will be detrimental for that particular cell. Besides the hepcidin, which blocks the ferroportin to absorb more, if there is a higher dose of iron, also the mucosa will be shed off. And this whole process leads to the shedding of the lining and leading to the side effects which we are talking about because of the GI tract side effects because of the iron. Now, this is called as the mucosal block theory or the mucosal iron blockage. So in simple words, if you increase the iron which is required and which is going to be able to be absorbed by the enterocyte, it is not going to help the woman. It is not so simple that, it doesn't matter, whatever surplus is going to be shed off as black colored stools. It is not as easy as we think. But the unabsorbed iron in turn will activate the inflammatory markers like IL-6 and HFE, which in turn are going to affect the lining of the enterocytes. Now, this is what we will also ask Dr. Gaurav Jain, who's the pharmacologist who's with us today, that how this increased iron is causing inflammation, and is it really true that it is causing the inflammation and damage to the enterocytes? This is what we're going to ask him by the end of the session, and we'll get some input from him. So, in simple words, a high dose of iron will lead to all those GI symptoms like abdominal discomfort, nausea, vomiting, dark colored stools, and constipation, which is going to make the patient non-compliant. Now, let's talk about this trap also. Okay. Now, what is this? The trap is this, that most of us, when we want to do good, we think that, okay, if there is less of hemoglobin, we need more hemoglobin rise. And for more hemoglobin rise, let's give more iron. This mindset of more iron will help in more hemoglobin rise is actually an unconscious psychological trap that we fall into. And this is the dosage trap of iron. Now, this actually has to be understood with this background, that the moment we increase the dose of iron, we are actually kicking in the hepcidin metabolism and the hepcidin feedback mechanism. And that in turn leads to, increased iron load in the mucosa, which in turn leads to the mucosal block theory, which leads to the mucosa to be shed off. And that in turn leads to actually the side effects. So I have talked about three components. One is the one-way metabolism of iron, how it is actually not passing through, and it is actually going to be, absorbed and kept in the liver for a long time in the form of ferritin. Second, I've talked about the hepcidin, inhibition of the absorption of iron from the mucosa or the enterocytes. And third, how the mucosal block theory causes it to shed off. So these three theories, if we are able to understand when we're talking about this, so we will not fall in this unconscious trap of dosage, where we keep on increasing the dose of iron, thinking that it will help. Now, there is no doubt that iron absorption enhances when the requirement is increased. But at the same time, we also need to know these things. So what does WHO say? WHO says that the dosing for iron recommendation, it has to be actually a daily dosing, a daily oral iron and folic acid supplementation with 30 milligram to 60 milligram or elemental iron, and 400 micrograms of folic acid in a pregnant woman. Well, they also have the guideline in 2012 saying about a context-specific recommendation, where because of compliance reasons, in the population with an anemia prevalence in pregnant women of less than 20%, there you can think of intermittent high-dose iron so that the compliance is taken care. So this is a very context-specific recommendation where the prevalence of hemoglobin is less. So many times, no, WHO is saying that you give it once a week, it's okay. Give a high dose of iron once a week, it's okay. No, it's not so. So we have to read the fine print, which helps us to understand that high dose of iron is only a context-specific recommendation. Okay, so we have to realize that. Now, prevention and treatment of iron, if we really want to look at the oral iron therapy, there is another thing that we need to understand, and that is about the different types of salts. Now, let me also talk about one of the salts that are also, which is also available, that's iron amino acid chelate. Now, how this amino acid chelate, its efficiency and safety is helpful, is that it actually absorbs much more, in the larger amount. The bioavailability is higher because it is not only, the iron acid chelate not only protects the iron from absorption inhibitors, but it also helps in higher absorption. Another very important thing about the amino acid chelate, which has come through from literature, is that it actually, compared to the other salts, it has got lesser GI side effect because of the lesser dose required, and is more effective and absorbed faster when the need of iron deficiency is there, and the rate of absorption is also higher. So in simple words, there is a merit to this salt. And there will be a lot of studies which have compared this. I'm not getting into those details right now, but it boils down to the fact that the compliance and the need for lesser dosage of elemental iron is what helps in scoring for an amino acid chelate over many other salts, whether it is a fumarate, amino acid citrate, or an ascorbate. Now, this is where it helps the side effects. So in clinical practice, when we are looking at high amount of hemoglobin level rise, then is there a study which says that yes, it is possible and it is happening? Well, we have to look at the various aspects of iron efficiency and aspects about compliance, and then we will be in a better position to say that whether it works or not. So if you look at the various parameters for efficacy of iron when it is getting absorbed, and the compliance from the patient when it needs to be taken, the factors which play is: one, what is the existing store of the patient? Second, what is the amount of elemental iron that we are giving? Third, whether it is getting affected by the diet when you're giving it, like for example, the problems with the phytates when it gets absorbed. Fourth is the bioavailability when it is given to the oral. Now, how much amount of it, what percentage of it is going to get absorbed? Fifth, the stability inside the GI tract when it is given in the oral form. When it reaches the GI, the gastric mucosa, and the impact at the duodenum, how it has an impact, it is very important. And then, of course, the form of administration. Lastly, how much iron are we giving? Are we giving higher than what we require, or are we giving optimal? Now, these are the factors which will help us to look at it. Now, let me quote an interesting study. I had personally had the opportunity to interact with Sunita Chandra, the lead author of this article. This is an article which is a very recent article in 2022 International Journal of Basic and Clinical Pharmacology. And Dr. Sunita Chandra had actually also given a presentation on this original study. And this information and data is coming from that article and from her. More than 95% of the patient adhered to the iron amino acid chelate preparation. And what was shown was, out of 66 women, only 2 had shown vomiting, and nausea and discomfort was pretty low. In simple words, the side effects was very less. Now, for those patients whose hemoglobin was very low, as low as 7.5, she mentioned and showed in her study that more than 3 gram rise was seen. Simple words, lesser the hemoglobin, more is the rise. Meaning, when the body requires more iron and more rise, then the body responds in that way, and the rise is higher if the hemoglobin is low. What about 9.5, which is one of the commonest levels, 9 to 10 that we see? Here again, the body actually showed that yes, even if it is not very low, but yes, at these levels also, there was almost 1.5 hemoglobin rise seen in the subsequent study, in the follow-up evaluation from the baseline study at 12th week. So not only does it help in increasing the hemoglobin in a patient with mild anemia, but when it comes to severe anemia, it actually happens faster. Now, this was one of its kind study when it talks about serum ferritin levels, because she had also studied the ferritin levels, and she showed that with oral iron, actually the baseline level of ferritin of less than 20 improved to more than 35, meaning the iron stores were also helped by giving this particular thing. Now, what about the patient adherence? Is it really an important factor? Well, most challenging thing that we see is that the patient is advised, and we're asking the patient to take an iron tablet all through the journey of pregnancy for 6 months, and then after that also. So somewhere around 200 plus days, we are expecting the patient to take the iron. Okay, when we are expecting the patient to take iron for such a long time, especially when she has anemia, it is not easy for them to, actually be able to take this for such a long time. So there are so many studies to talk about that. And that is where actually we talk about the need for lesser dose of iron giving higher efficacy and lesser side effects. Well, when we talk about the GI inflammation in IAC, our $1 million question is that if we are asking a woman to take it for more than 200 days, is she going to tolerate it? Is she going to actually stick to the protocol and be compliant to it? So tolerance and compliance, these are 2 extremely important perspectives when it comes to patient. And third, as clinician, we want it to be efficient, and efficacy should be there so that it gets absorbed and it shows us the desired result. So if all these 3 things work, then it makes sense. With this background, what I'm going to do is I'm going to now request, just a moment. I'm going to now request Dr. Gaurav to come into the play. And even before Dr. Reshma formally introduces you to Dr. Gaurav, I have a preset question which I'm going to ask you to look into it. So I came across and interacted with him about the scintigraphy study, which talks about the impact of inflammation and whether it is really happening in the GI tract, because of a whole fundamental, the critical pathway for our iron management in a patient for anemia is whether the iron is going to get absorbed or not. And second, whether the patient is going to tolerate this or not. And third, how can we make the patient feel that, okay, this is fine, and the symptoms are not so bad, so you can take this iron, because everybody says, no, I don't tolerate iron. Doctor, mujhe to tolerate hi nahi hota. We don't want that. So I want you also to answer not just hardcore pharmacology, but also the clinical pharmacology part of it. Over to you, Dr. Reshma. Over to you, Dr. Gaurav.
Yeah, thank you, sir. Thank you, Dr. Mukesh. Thank you.
Reshma, are you there?
Yes, I'm there. So before we begin, let's introduce Dr. Gaurav. Dr. Gaurav is an academician and researcher with more than 17 years of experience, a quite rich experience, who has completed his PhD from Jamia Hamdard, New Delhi. He is a Vice President, Indian Pharmaceutical Association, Delhi, holder of one of US and 8 Indian patents. He has more than 130 research publications in peer-reviewed international journals. He is actively involved in consultancy to pharmaceutical companies, authored 5 textbooks, including renowned 4th edition of Lackman and Diverman's textbook of industrial pharmacy and theory and practice of physical pharmacy. So welcome, Dr. Gaurav, and we would like to hear from you what new we can bring to the research and what is more important for us.
Thank you, Dr. Reshma. Thank you, Dr. Reshma. I will share my presentation. I hope it is visible. Fine. So I do agree with Dr. Mukesh that increased iron does not help. After conducting these studies, I must strongly agree with Dr. Mukesh that increased iron does not help. And to test this hypothesis, we have conducted a very unique study. See, iron causes mild inflammation. More of iron in the body causes mild inflammation in GI tract. And this inflammation is very difficult to analyze. Why? Because we have ultrasound, which is not able to analyze the mild inflammation in GI tract. Then we have endoscopy, which is very invasive procedure. So not many volunteers or patients undergo endoscopy. And during pregnancy, there are a lot of physical changes to the body also, through which this mild inflammation get unnoticed, but it can cause long-term problems. Therefore, we have a unique solution to this. So this already explained. So we have unique solution to this, that we have conducted a WBC scintigraphy. So neither I am a gynecologist, neither I am an iron specialist, but yeah, I am a researcher. So what we find that the white blood cells which are in the body, they easily transport, they get liaison with any inflammatory site or any infective site of the body. So this approach we have utilized uniquely in this particular study, because by any other technique, we are not able to analyze this mild inflammation in the body. Therefore, we use WBC scintigraphy, which is for the very first time we have used for this particular procedure. Now, scintigraphy per se is a nuclear imaging technique, very old technique, where isotope is given in the bloodstream for diagnosis. But here, we are not using it for diagnosis. We are using it for evaluation of a pharmaceutical product, which is very limited technology, and which we are doing for the past 10 years or so. Now, what we have done in a simple manner, we have taken blood from the subject. We have extracted WBC by our in-house procedure. Then we have radio labeled these WBC. So radio labeled that we have attached technetium. Technetium imparts radio label, which can be assessed via gamma camera. Now, these radio labeled WBC are again injected back to the patient body. So this we have done before the therapy, before we are starting the therapy, and after say 200 days after completion of a therapy. So what iron is doing to the body, to check this, we have conducted this trial earlier and post therapy. Then patient lie down and there is a gamma camera which can assess whether this WBC is going in a blood flow or it is accumulating to a body. If it is accumulating to a particular part of the body, this indicates that whether there is inflammation there or there is a infection, because there is a chemotactic attractions of these WBC with the inflammation infection site because of prostaglandins and IL surge. Now we have taken images means before the therapy, at the baseline, and after the therapy, and various other lab tests are done. So these are few images which highlight that whether there is inflammation or not. The first red lines indicates that yes, there is an inflammation in the stomach. So you can see that the arrow part, that the arrow showed below duodenum. So below duodenum, there is an inflammation. So in small intestine or duodenum, there is accumulation of WBC, which shows inflammation in these area. But in the second image, there is no inflammation, because as per se kidney emits more amount of drug, so therefore kidney is visible in second radioisotopic image. So but there is no image below the kidney. This indicates that there is no inflammation. Then, so we carry out this study, which is first of its kind study, where we evaluated low dose iron, 30 mg iron versus 100 mg ferrous ascorbate iron. So we will just, so study, I'm coming on to directly onto the study results. So first result is it is in corroboration with the results obtained by Dr. Sunita, where we have also observed that if we are taking the low dose iron, that is 30 mg iron as amino acid chelate, the rise is 0.5. This is rise in hemoglobin as compared to 0.32 in ferrous ascorbate group. So if we compare these two groups, we can see that rise is 56% higher in our study. Then in the second part, we evaluated safety, which is as Dr. Mukesh said, which is in long-term iron therapy, safety or tolerability is an important thing. So when we assess safety, we see that in ferrous ascorbate group, in 34% of the subjects through WBC scintigraphy, which is again a unique trial, because if we have parallelly conducted ultrasound also, which is not able to give us good result. So in WBC scintigraphy, we are able to see that 34% of subject experience inflammation after 1 month of therapy with iron 100 milligram. But when this iron is 30 milligram, there is no inflammation observed in any of the patient. So again, our results are in corroboration with Dr. Sunita's result, where she has found that in more than 95% patient, tolerability is there. And this tolerability is because of the safety of the product. And I also, I strongly agree with Dr. Mukesh, where he has said that if low iron is there, its absorption is proper from the proper site, because this is iron as amino acid chelate. So they use a patented technology where vegetable proteins are hydrolyzed into amino acid and it is chelated or complexed with the iron. Now this complex remains insoluble in the stomach, so it does not absorb in the stomach. But as we move down in the duodenum or small intestine, this is hydrolyzed, this is broken up, and this iron from the small intestine, which is its primary site for absorption, is absorbed, and it does not causes GI inflammation as observed in the study results. The third part, which is very interesting, is tolerability. And we again found that the blue indicates absence, the orange color indicates mild, the bright yellow indicates moderate, and the red indicates severe. We see that in case of nausea, vomiting, metallic taste, abdominal pain, and treatment withdrawal, in all these four things, amino acid chelate, which is low dose iron, the hedonic scale says that, or the patient data which we have received over a period of 1 month says that this is absolutely absent. No patient observed nausea and vomiting, metallic taste, abdominal pain, or you can say very few patients have experienced this, and overall score is less than 0.5, which indicates that it is absent. And GI upset and blackening of stool is moderate. We found out that because some part of the iron remain unabsorbed, which comes into the stool, and therefore this is moderate in few subjects. But comparatively, as ferrous ascorbate group shows that in all four parameters like nausea, vomiting, metallic taste, abdominal pain, and treatment withdrawal, the observation is mild. This means it is not absent. Some patients observe nausea and vomiting, they report metallic taste, they reported abdominal pain also. Particularly in patients where we have seen inflammation, they reported GI upset and abdominal pain. And as can be seen from the data, GI upset is severely reported in case of ferrous ascorbate, which is high dose iron. And again, blackening of stool is also reported. So the test of this hypothesis says that that Dr. Mukesh hypothesis was correct, that low dose iron, if it is absorbed from a proper site of the body, if it is going through a proper mechanism, is only effective for increasing the HB. So it can cause efficacy also, it can cause safety also, and it can be tolerable from patient perspective, and having a better patient acceptability also. So our study highlights that low dose iron as amino acid chelate compared to ferrous ascorbate is found to be high on efficacy, high on safety, and high on adherence and patient compliance. So over to you, Dr. Mukesh. I hope I am able to justify your hypothesis through my small studies, which have been conducted on limited number of volunteers.
So I think, thank you so much, Dr. Gaurav. You know what, as a clinician, we always feel is that we read so many things in the books and we read so many articles in the journals, and then we create a funda that maybe it is going to be working or not. So I think we had this theory about the, again, I'm going to, for the sake of people who must have joined in late, that what is the one-way metabolism of iron, where it is only going to be absorbed as per the requirement, because there is excretion which is happening is very, very limited from our body. So absorption has to be grossly and mainly controlled when it comes to iron metabolism. So that's why it's called as one-way metabolism. Second thing was the hepcidin pathway, the hepcidin feedback pathway, which actually helps in inhibiting the absorption of iron because of its action on ferroportin. So whenever there is excessive iron coming in, actually it kicks that mechanism of reduced absorption. So that was one thing which was heavy on our mind. Does it really happen? And third was that the mucosal block theory, that whether the mucosa really lands up with inflammation. So now I'm going to, for the benefit of the people, I'm going to ask you in some simpler way, Dr. Gaurav, if you are comfortable with that, when we are talking about this scintigraphy, now, why do we, so what we understand, correct me if I'm wrong, actually you give an isotope and add it to the WBC and then check with the gamma camera, right? Gamma scan or something like that, is it?
Yes, sir, absolutely. It is like MRI only. So instead of like we give isotope, which is radioactive, and that isotope, when it moves in the body, we can track its movement through gamma camera. Absolutely. So technetium is most widely used, and it has been used in diagnosis also, but we are utilizing it for evaluation of drug products and you creating brand awareness, and also during drug development also. So we are doing studies for we labeled it as bioscintigraphy or pharmacoscintigraphy.
Oh, interesting. So I think what we as clinicians were feeling, that whether it is really getting impacted or not, was that the inflammation. So you postulate that, or rather you interpret that because the increased WBC is getting accumulated in the GI tract reflects that there is inflammation. That's what you say?
Yes, absolutely, sir. Because there is no way by which we are able to access this inflammation, the mild inflammation particularly. So yes, this is my last verdict, like from this studies, that WBC will accumulate there, and we can identify its accumulation from the baseline. We can check it with the baseline. Any accumulation, any change in, you can say, drug perfusion rate will give us hint about the accumulation of WBC in that particular part of the body.
Okay, so your study showed that with a higher dose of iron, the inflammation or the WBC was more. That's what you say. I think we have lost.
Undesired site is more.
Okay, so this is an interesting thing which I always wanted to get a proof of it, right? So your study says that. Now I want to ask you another thing. As clinicians, we can't do scintigraphy in our pregnant women or any other things, So is there any other investigation? You mentioned about the sonography and its limitations. Can you highlight a little more about that? Can we just figure out whether the patient is, so for example, if my patient is happy, we have been using so many salts for such a long time. If my patient is happy and we are wanting to just say, let's continue with whatever iron forms and whatever dosage we have been using. In fact, my pain point, you will be shocked, is sometimes I see prescription where people are given 100 milligram BID and TID, So,
yes.
So I want to give a take home message to all those people who are watching, all of my colleagues, that if we give 100 milligram BID or TID, and is there a way to figure out by us as clinician without scintigraphy that is it causing inflammation at GI and causing side effects?
So per se, it's very difficult. First, I'll emphasize that excess of everything is bad. But the first view is that blackening of stool. So by comparing the blackening of stool, which is absolutely non-invasive, we can identify it, because gamma scintigraphy requires a specialized technique, and so it becomes difficult, although it is non-invasive. But to do it in a routine practice will become sometimes challenging. But yes, I I can also say that something is happening inside. If there is some GI problem that is occurring, and through analysis of various other factors like absolutely there is a mild to moderate pain in the stomach or blackening of stool, so we can club these.
No, Gaurav, we are a pharmacologist. I'm going to dig into what you have been doing. The clinically, though we know, Baba. But what my
Yeah.
concern is, you mean to say that there is no clinical test which will tell me, and hence we have to understand that this kind of study is something which represent that inflammation is going to be there. Okay, am I right in interpreting this?
Yes, sir, absolutely right. But again, specialized equipments are required for this study. So might be we were switching over to handle equipments, which make the process easy. So they are near future. Then again, very important thing is patient feedback. So we can collect response over say 1 week's time, and that patient feedback along with the examination of physical parameters will give us a right idea. But again, conducting this study in pregnant women is challenging, is a bit challenging. Yeah.
So this is an interesting information. So I would, as a clinician, like to summarize this information which I have got from Dr. Gaurav, that ultrasonography may not be reliable to predict. You did sonographies for any of these patients when you were doing the study?
Yes, we have done, and the results were 50% less. So because if there is a mild inflammation, that sonography will not able to detect. And this mild inflammation is, we are able to detect this via WBC scintigraphy, and that is the uniqueness of this procedure.
Okay, so
And
I'm going to make two corollaries from the information that you give. Number one is that if we are thinking that by doing a sonography and looking at the inflammation, number one, it also depends on the machine that is being used. Number two, it depends on the person who's doing it. And number three, even if it is mild, it is going to be missed out. So all three factors are not going to lead us to the clear information whether actually the inflammation is happening or not. And whereas in your non-pregnant data that you have presented, that yes, there is an inflammation which is setting in, and that is, now I have another take on this. If there is a high amount of inflammation in a patient who is taking iron, the serum ferritin levels actually are also going to get altered.
yes.
So that is also because all the studies, they mentioned that when you're doing serum ferritin levels to assess the stores, it should be a situation where there is no infection or no inflammation.
Yes, definitely.
So that's an interesting thing, that we give high dose of iron and then the inflammation is setting in, and we are not even coming to know by sonography or whatever investigation, and then we are actually causing poor compliance, etc. So that's an interesting information. And the second corollary is that we cannot wait for the inflammatory signs, and we have to judge from the patient's clinical findings and from the patient's feedback. That's what you say, right?
Yes, absolutely, sir.
So I think this is a very comprehensive message to give for take home for our people, that look here, that if we go for higher dose of iron, it doesn't mean that we are giving extra benefit to the patient when it comes to iron absorption. Second, that it actually, our primum non nocere, first do no harm. Okay, so we always say that the four pillars of ethics, the first pillar, although maybe autonomy, but there is something called as beneficence, non-maleficence, and we need to look at that patient should benefit from what we are doing. So by giving high dose, we are not benefiting the patient. That's an interesting take-home message that comes from this. Now, second component I want to, you mentioned when you were talking in your presentation that you used a hedonic scale. Now, I have done my postgraduate in psychological counseling, and I'm using this many times. So for people who are not very used to this terminology as hedonic scale, basically it is more to do with patient's feedback. So initially, when I talked about the theory and the clinical issues and the clinical problems and the clinical perspectives, and that was my part of the session where I was really keen on putting across our challenges and how we have to understand the various different theories. And then Dr. Gaurav took over and he explained about the science, that this is what the science says, and that is why these theories hold good. Now there is another component, the last component, and that is patient centricity. So you keep on mentioning that you have to focus on patient feedback and you focus on clinical science and everything. Now, I want you to tell us that some insights once again. I know you did mention about it, but I want a little more clarity on what was the feedback in the hedonic scale when you did from the patient perspective. Because at the end of the day, a clinician's main job is that the patient should be healthy and yet they should be happy with what we are doing. Right? Because in this era of patient satisfaction, if we do not satisfy or do not have a good experience for the patient, they're going to be really sad with us. So what was your finding on the hedonic scales?
Sir, as mentioned in my presentation, I found that in case of nausea vomiting, so we selected the major drawbacks of iron therapy, like nausea vomiting, metallic taste, abdominal pain, GI upset, and blackening of stools. These are the major, and withdrawal. Yeah. So we found that when we are taking low dose iron, in most of the patients do not report any case of nausea, vomiting, or metallic taste. Abdominal pain is also absent, and there was no treatment withdrawal. So there are very few, if I review back to the data, it is 0.17, 0.33. So that is less than 0.5 on hedonic scale, which says that it is absent. Because if, say, out of 20 people, one is showing a symptom, so that is considered to be as an absent. But in case of high dose iron, we find that all these nausea, vomiting, metallic taste, abdominal pain, and blackening and treatment withdrawal, they are mild, so they are present. And GI upset, which is very common problem with iron therapy, is moderate in case of this our low dose iron, whereas it is severe in case of high dose iron. So because I think that this is due to the site of absorption of iron, which plays very, very important role. Ionization of iron, which plays important role, which causes inflammation as well as severity in case of hedonic scale when we look into ferrous ascorbate group. Again, blackening of stool is problem because whether it is 30 mg or it is 100 mg, some part of iron will remain unabsorbed. So that will come into the stool, and this causes blackening of stool. Again, very important thing here is we should always compare how much black. We leave this, it is black, so black. But we should compare how much black, because that will give us the real emphasis that how much iron is coming unabsorbed from the body. So that is also very important, which is severe in case of ferrous ascorbate, and which is moderate in case of iron as amino acid chelate, which is low dose iron.
That's very interesting thing, because so for those who did not understand this hedonic scale, once again, so when we evaluate whether it is patient is happy with that thing or mildly unhappy or moderately or severely unhappy, that is the kind of scale that we are talking about. So what you say is that most of the patients with high dose were not happy with those side effects, especially the GI.
Absolutely.
And especially the because of
GI
the high
upset in case of high dose.
Yeah, but there's another very interesting thing you mentioned about watching your potty. so this is another interesting thing, because we have been taught that, okay, just check whether the potty is black or not. If it is so, if your stools are black, that means you are having good amount of iron and the surplus is being thrown away. Now,
yes.
When we hear it from an expert who's mentioning that it is not just the quality but also quantification, which is an important thing, that the very fact that high amount of black coloration is happening, that means there is a higher amount of iron which is being pumped out of the body, which is surplus and not being absorbed, and we are giving unnecessary iron to a patient who does not need it, or the body is rejecting its absorption purely because of surplus dose. And by the surplus dose, we are actually causing side effects which are not what the patient wants to take. And now this side effect in turn reduces the compliance for taking the iron, which is primarily intended by us, that please take the iron because we want the hemoglobin to rise. Meaning at one end, we want the hemoglobin to rise and they need to take the iron. But at the other end, because of the kind of dose and because of the kind of protocol that we are giving, the patient is not taking it. So instead of doing benefit, we are causing harm. This is amazing. Right, Dr. Gaurav?
Yes. Absolutely, sir. Take home should be that we have to take half the existing dose. Like if we are taking 100 mg, it should be either 30 mg or 50 mg, or we have to reduce to, or we have to switch over to some other salt.
Oh, that's an interesting thing. So I think this is an interesting information that we've got. And in this era, how much time do we have, Reshma, left? Because I was told that we have to wrap up at 9.
7 o'clock. Yeah.
Yeah.
But
because this
I need you to.
So
no worries. Even we would like to hear from you. So you may please take 5 minutes more.
Okay, so this conversation was very, very, it's very rare that us clinicians get a chance to do one-on-one with a person who not only has a medical professional awareness and knowledge, but also is deep into the science of proving our clinical theories and our clinical beliefs and proving it by actual science. So one last thing that I'm going to trouble you with is that when you say that these studies were done in non-pregnant state, obviously in pregnant state, it's going to be difficult. Now, there was this study which we saw about the iron amino acid chelate, which says that at a lower level, the absorption is more. Okay. And at the higher level, the hemoglobin rise was lesser. So what we interpret is that when the body's demand, or rather demand of the body is more, then the absorption is more. And when the demand is less, the absorption is less. So will it also have an impact on the inflammation?
Yes, sir, definitely. Because whatever is left unabsorbed will first cause some harm to the body, then it goes out of the body. So if anything is unabsorbed, that is causing the harm. Once it is in bloodstream, it won't cause any harm. So when it is unabsorbed, it is moving through GI tract, it remains there and it is causing harm. So it's, yeah, definitely.
So that's interesting. So Reshma, if there are no more questions, we'll take some take-home message from Gaurav, and then I will wrap up my take-home messages.
Definitely.
So my take-home message, my take-home message is that again from the Dr. Mukesh only, increase iron does not help, and dose optimization is very, very necessary. And we should regularly check our potty when we are when we are on iron therapy.
So when I was traveling to one of the Scandinavian countries, and I saw a poster there that look at your potty before flushing. And there was a campaign from the health department of that country that before flushing, check your stools, because our Indian culture, we were talking about the Indian methodology where we were actually able to see before flushing. But when we started moving on to the Western commode, and then we suddenly realized that even before we get up, we flush it. Okay. So we have stopped watching and actually looking at this is getting mad. But
sir, sir, if we look into like when we talk about our children's, when infant is there, we analyze his or her potty. So that's preliminary thing. But when we grow old, we stop analyzing this.
So I think we should look at that. So that's an interesting thing, because my main understanding of this is that actually what was just a feature for ensuring compliance is not really just compliance, but it's also about a marker for unnecessary side effect, which is being caused by surplus dosage. So this is a shift in thinking, and it is time that we have this, change of thought process, that by giving surplus iron, we are going to help the patient. Actually, we are going to get into that unfortunate trap of mindset, a psychological feeling that, okay, by doing more, we are doing good. When on the contrary, by giving more than what your body demands or requires, we are actually causing more harm rather than more good. And I think with this conversation, I will just try to end one last thing. At the end of the day, it is our intention as our purpose path to do good for our patients. And as clinicians, we always strive to figure out better ways and methodology to see to it that our patients benefit. And in our journey in this patient centricity and trying to get a better patient satisfaction and experience into the journey of pregnancy, because this is one of the most memorable journey or the most tragic or horror story, which a woman says the journey of pregnancy. If we are able to give her something which she's actually badly needing, because we all want to give her iron, because otherwise we are really worried about not just A, the Barker's hypothesis causing side effect to the baby, B, the complications to the woman during the journey of pregnancy, C, the postpartum hemorrhage, which is the most dreaded, and lastly, the journey of mother during the breastfeeding because of low iron causing anemia to the newborn. From all perspective, it makes sense for us that the woman takes the iron and she takes those medications that she's been prescribed. But unfortunately, in our overzealous attempt, we may fail drastically in helping her, and instead of that, harming her, which we really don't want. Thank you so much for all the inputs, Dr. Gaurav. It was really nice as a clinician. And I think although the team from, Lupin, etc., were trying very hard to create this conversation between two of us. And I was also extremely curious and now satisfied that we had this conversation. Thank you so much. Thank you very much, Reshma. And thank you, Dr. Gaurav. Over to you.
Thank you,
sir. Thank you.
Thank you. Thanks to both of you, because it was a wonderful experience to hear from a researcher what he actually did and how this entire experiment was carried out. And further, Dr. Mukesh Gupta, your tips and tricks are always helpful for a pregnant woman as well as for all the other practicing physicians also. How do they subjectively manage their patients? That's a very important step, I would say, how a subjective management would help each and every patient. I will not say a patient because we always say about a would-be mother. She is a would-be mother and not a patient unless and until she is having any confirmed disease or anything confirmed medical condition. So every would-be mother should always be protected, as well as she always have some benefits out of her therapy. So this is one thing which I would like to focus. Yes, lower dose is one of the key factor, and then subjectively one can adjust the dosage for each and every requirement. So thank you, sir, and thank you, Dr. Gaurav, for all your
Thank
technical inputs. And we can end this session. We thank the technical support team as well here, who has